Welcome to the Codecast podcast. Real-world insights for your daily medical coding and billing processes. And now, here's your host, Terry Fletcher.
Hello, everyone, and welcome to the Codecast podcast. I want to say Happy New Year first. I know that we are December 31st. I hope everyone had a good Christmas and Hanukkah and that you're getting ready for 2025. So this is our Top 10 Tuesday. Again, we don't miss a Tuesday, even with the holidays. So let's go ahead and get started. So we have some interesting questions this month, and actually I think you'll find them helpful. I'm going to put it in a blog form as well and put them on my website so that our members and non-members can also read through them. Because I think the answers and a lot of the questions may apply to many offices, many practices. So the first one is on data points for E&M services. And it says, Terry, this question for you on data points is probably a simple one, but we're trying to figure this out. Can you help us out? Provider reviewed a previous CT scan completed by an outside specialist, then decides to order another CT scan to see any progression. Can we credit 2 points in data for the review of an outside CT and then the order of the new CT for comparison? Same CPT code. Actually, yes, you can do that because you had another CT that you didn't order before, and now you're ordering one for comparison. So even though it's the same CPT code, it's not the same CT scan. So that's actually a really good example of when you can get both the review and order under the same encounter, and that is rare. So great question. Number 2, now this one, oh my gosh, talk about the Christmas season, and I had to be Scrooge. When a family member calls to make a payment for a patient, would it be acceptable to accept the payment even if the person calling is not listed on the release of medical information? The scenario for us was a family member calls in to make a payment for Christmas. They ask what the amount the patient owes. We verify they're not on the list of release of information, which a lot of people don't do, so I'm glad we at least have that protocol. But I said we can't provide that information, but they still want to make a payment, so they just pay the amount they think the patient owes. How are we dealing with that? Well, this is a lot to unpack, so I apologize if this is a lengthy answer. First of all, you're 100% correct as far as compliance with HIPAA. If they're not on the release of information and they're not one of the approved people for the patient, then you can't give them any information for medical, and that includes what they owe on their account, which is kind of sad because I wanted to do that a couple of times for somebody and you can't do it. Second thing is that if they make a payment and it's more than what the patient owes, the refund can't go back to that person. It has to go back to the person who's on the account or the subscriber. And so that's where you've got a tricky situation, because now you're sending money that wasn't paid by the patient, but because it's the patient's account, you can't send back something to that person who made the payment, because now in effect you would be telling them what was owed. All they have to do is simple deduction. So when people call to do that, you might want to just let them know that maybe put it in a card and, give them in a card to them personally towards their medical bill and write the practice name on it since they knew that they were seeing the doctor there. I mean, that's not something you disclose, that somebody told them that, and just give it to the patient and then they can, make the payment. So I know that's a tough call. They want to do it as a surprise, but the surprise is they're making a payment for them and they just need to make it directly to the patient, and they can always write a check made out to the clinic since they already know it's the clinic and that's not something you disclosed. Tricky situation there, but HIPAA's HIPAA. Number 3, do you consider a decision for a pain injection without specific patient-identified risk factors low or moderate for medical decision-making? I actually consider that low if there's nothing in there except the patient, is just agreeing to have an injection. I know there's something as far as minor surgeries with identified risk factors under moderate, but because this is low risk for morbidity or additional diagnostic testing or treatment, especially with the lack of any kind of risk factors, I don't think you can get past low. Now here is, the fourth question is interesting because it kind of builds on the third question. So different encounter is giving a joint injection for pain considered moderate under the risk of prescription drug management. So we've had several Medicare carriers answer this. Medicare carriers, yeah, I think I said medical, but the payers. And Noridian stated it best, and this is where I'm quoting from their website. It says, no, simply giving a pain injection is generally not considered prescription drug management, and they emphasize that with quotes, under E&M medical decision-making, as the act of administering an injection in the office does not involve the same level of medical evaluation and management as prescribing a medication that the patient will take at home. Therefore, it would not typically be used to increase the E&M level based on medicine management alone. So that's pretty clear. Also remember a couple of things about, prescription drug management and that moderate level of risk. This refers to the provider's documented evaluation of the patient's medicines, their medications, including decisions to start, stop, change a dosage, or to continue on medication, which usually involves a prescription sent to a pharmacy. So, for example, I'll give you a personal example. I was taking a cholesterol medication that I'm no longer taking because I found out that cholesterol medication, as a general rule, not even a specific one, but generically, I've tried two now, actually increases inflammation to joints and tendons, which I couldn't understand because I've got frozen shoulder, why it was starting to be inflamed every day. I stopped the cholesterol medication, and sure enough, the pain minimized, didn't go away, but it wasn't as much. So that's prescription drug management, because the doctor tried a couple of different things, said go ahead and not take it for 2 weeks. Let's see what happens if there's a change, and on and on. So we decided that because my labs looked good and I was in normal levels, that apparently I've adjusted my diet for that and I didn't need the inflammation going on. But that's what we're talking about as far as medication management. Now let's talk about that injection for example. So while the injection itself is a procedure and you're billing it separately, the decision to administer the injection might contribute to the E&M level based on the complexity of the patient's condition and medical decision-making process involved in choosing the injection as the appropriate treatment. But complex medical adjustments, this is what you'd have to have. So there was something that would reflect that, the dosage you used was carefully calculated based on the patient's response or other factors. Again, the decision-making process. Was there any side effects that you were concerned with, potential adverse reaction, based on the patient's clinical profile? You can't put it in generically. So that's where you have to be very cognitive of the fact that you can't inflate or manufacture things just because you need them in your E&M services. Number 5, in 2025, since we got a 90-day extension for using telehealth when the patient is in their home, irrespective of diagnosis or geographic location, we can still bill our telehealth services for the first 90 days. So it'll be until March 31st, 2025. So I just had to remember where I'm going. I even said Happy New Year. I also did a podcast on this last week, so make sure you take a listen. But there was a question that came up, what about audio only? Oh boy, talk about a tricky question. So in the final rule, it said that audio only is tied to behavioral health, end-stage renal disease services, and SUD, which is substance abuse disorder, which falls under mental behavioral health. And they said only if the patient either refuses or can't connect, even though the physician is able to connect audio and video, or if the patient doesn't have good internet. And I would document that because it's going to be questioned. Then there's a possibility you can have audio only in that circumstance, but they tied it to specific diagnoses. So since we lost all audio only codes, the 99441 to 443 is deleted, and Medicare's not recognizing the new CPT codes for audio only, then no, there are no audio only codes except the virtual check-in, which has its own rule, the 98016, and you can't use it if you end up seeing the patient for an in-person visit or an audio only or audio and video visit. It would be included, and that's only worth $9. So, and also remember, I don't even know if you've checked, but the telehealth approved list that the latest one was November 16th, that's actually disappeared from the CMS telehealth website. So the last one I have is 11/16. They took them all down. I think they're waiting to rework that with the new incoming HHS secretary and CMS administrator. So just know that is my That is my interpretation of the rules right now, and don't think it was a mistake that Medicare put invalid on those audio only codes. If they wanted us to have audio only, they would have opened them up as active, and they did not. So please, unless you have those diagnoses, do not think that you can go ahead and bill audio only for everything, only for specific behavioral health or end-stage renal disease. Number 6, I have a question regarding fracture care and when it begins. If a patient goes to an emergency room for a fractured finger, which is diagnosis S62.609A, that means the initial encounter, and gets an x-ray and a splint, then is referred to a specialist, when does fracture care begin with the fracture care CPT code? The first appointment with the specialist, so initial encounter for fracture doesn't always mean the initial visit. Is it to define, active care for the fracture? So a patient can receive active treatment for a condition beyond the initial visit. The Chapter 19 guidelines confirm, and I'm quoting from the guidelines in ICD-10, it says, while the patient may be seen by a new or a different provider over the course of treatment for an injury, assignment of the 7th character is based on whether the patient is undergoing active treatment and not whether the provider is seeing the patient for the first time. So assuming the provider is providing active care, the 7th digit of A is appropriate regardless of how many times the patient or the provider saw the patient previously. So examples of active care are surgical treatment, ER department encounter, or an evaluation and treatment by a new provider, new physician. So initial encounter, it seems to crosswalk over to active treatment. We have been receiving denials, number 7, from Humana Medicare Advantage for GO105, colorectal cancer screening, colonoscopies for individuals of high risk. The reason is incomplete or invalid principal diagnosis. What we've been listing is either Z80.0, family history of malignant neoplasm of digestive organs, or Z86.010, personal history of colonic polyps. All denied cases include findings of diverticulosis or hemorrhoids, but there's no evidence that the conditions necessitated the intervention, so the procedures did not convert to diagnostic or therapeutic. Okay, so here's the problem that you have, not just with a Medicare Advantage or commercial plan, but even Medicare. According to a catch-all, and this is a catch-all, colonoscopy screening policy, I should say colorectal cancer screening policy, diagnostic, therapeutic, surveillance colonoscopy for diverticulosis or hemorrhoids are not medically necessary. So it seems that they've got an edit, and they do, and they confuse the coding scenarios. But if the patient is there for a screening with no complaints, no issues, but they still have diagnostic diagnoses on the claim form, it's going to get kicked out. So Z12.11, that's the screening for colorectal cancer. When I see that you're using Z80.0, that is for digestive organs. There's no screening benefit for malignant neoplasm history of digestive organs. There is for personal history, but not if you also have diverticulosis or hemorrhoids. So this is where you have to know what the intent is for the patient coming in. Again, the only exception is if it turns out to be, you end up removing a polyp, then your listed code would either be your personal history, Z86.010, or your screening code, Z12.11. But then that would point to, that would be the first listed code, but then your second code would be what you removed, whether it be a malignancy or a D code for the benign polyp, wherever the location was. And then the patient wouldn't have a deductible, but they'd still be responsible for their coinsurance, or now in 2025, it's 15%. Also remember, if you do an EGD on the same date as a screening, it negates the screening column for the share of cost for the patient. I've seen that all the time. Also, it negates their out-of-pocket benefit, or I should say share of cost, where they wouldn't have it on the anesthesia as well. So be careful when, your physician's trying to, I don't want to say up code, but code everything that's there when it's really unnecessary for that particular encounter. It could hurt the patient from their out-of-pocket and their screening benefits when it's not necessary. Number 8, are there specific recommendations for physician signatures for care management codes? That's a good question. For example, does a physician need to sign off on all individual notes for beneficiaries from the care manager over the course of the month, or would summary statement at the end of the month suffice? So there actually is a physician signature Medicare pamphlet that they put out. It was actually just updated last July. And if you're a member, if you're one of my membership clients, please email me and I'll send it to you. But there are only general rules of signatures, and it's not specific to care management or anything. It basically says the services need to be billed and are signed before billed. And this is the only way to show physician involvement. So what would I allow from an auditing perspective? If I was auditing, I would want to see something that reflected the physician either signed off on or initialed and is monitoring that patient during the month. And then at the end of the month, the summary statement needs to be signed. So I think it needs to be both. Number 9 says, I have a couple of claim denials that I need your assistance with. And they were very sweet. They said, and thank you. We love our membership. And we're on our 3rd year now, and we love everything you're giving us. So they're from Iowa. So thank you guys. The first one is a Cigna denial stating that an implant device code is missing. Not sure what that's about. We're doing EP and pacemaker implants. Oh, okay. So with device implants, serial numbers of the actual device, the brand, and descriptor has to be in the operative notes. So I don't know if you're aware of that. So the authorized code definitely isn't what was done. It has to be. It's not just what was done. It has to be the serial number and the actual device information. So the codes on the procedure note may be correct, but if they don't see the actual serial numbers for that, then you can get kick out. Actually, it's interesting that this question came in because I did a DOJ inquiry they were getting really not happy with the hospital that was doing a lot of pacemakers and ICD implants, and all of their internal records did not have, the company, the what kind of device, and the actual device that was done, the brand, the descriptor, all of that. And that was a problem because a couple of devices were actually faulty. The patient had to go back in, have some of the leads and electrodes redone. And that's one of the biggest things. When you implant a device, it has to be in the notes. So it's not just something that somebody has to look for. It's actually, easily looked at within the note, and it matches what the descriptors are. The last one, number 10, says, I have a neurosurgeon ask me to bill for a first assist in his surgery, but the first assist he wants me to bill for is a surgical tech, not a nurse practitioner or PA. The provider pays the hospital's bill for this all of the time. The provider says the hospital bills for this all the time. In the research I'm finding, the first assist needs to be NPPA or clinical nurse specialist. Okay, so let's talk about assistant in surgery. Okay, so they can also be RN first assist. So many of you have heard me say back in the day I used to be an RN first assist. So I was a nurse with first assist. But it's hard to be a nurse when you don't like the sight of blood. So yeah, I went into the administrative and the business end of medicine. But I have the clinical background. And when I did assist, they would attempt to use the 81 modifier, but that's rarely paid because that's a clinical person. They were more... we were more an extra set of hands because there were a PA or a nurse practitioner is not available. But you are correct. The person who asked this question has to be a physician or QHP to get paid for an assist. The surgery also, remember, has to be on an approved list for assistant at surgery. Not all surgeries where the physician wants an assist will warrant payment. So you have to make sure you're looking that up. You can Google it too. What requires an assist at surgery, and you can also find it in your hospital. So make sure you ask your hospital surgery exec committee what that is. And then remember, under the facility payment, hospitals can charge for things that physicians cannot. It comes with their package. The surgical technician is not a payable service for a physician. They're helpful but not billable. Other issues is medical billing for surgical assistants. So CSFAs, CSAs, SACs, and LSAs. They're much more difficult, to bill or even try, for an MD because you've got state-to-state legislation that either does or doesn't allow it. Individual insurance companies can vary how they deal with surgical assistants from state to state, and most people use technician or technologist interchangeably, and there is a slight difference. So a technician typically refers to someone who has been taught the skills on the job or passed a training course, where a technologist usually has earned a degree from an accredited program. But these are not paid under the Part B physician fee schedule or under most commercial plans. So unless your physician is pulling in a PA nurse practitioner that, remember, they have as an employee then you can't charge for that. So they can't charge for any hospital employees because you can't pass along an expense to a patient that you didn't incur. So just be aware of that, and then also make sure you have your list of what assistant at surgeries actually are. Okay, hopefully you appreciated the top 10 Tuesday this week. And again, I hope you have some low key. I always say that because I'm not somebody who likes to go out on New Year's Eve. I like to make sure that I'm just, low key. We usually watch a movie and, grab a pizza or something. And I'm really weird. Once Christmas is over, I want my decorations down because then my housekeepers come the next day and get rid of all the clutter. I hate clutter. It drives me crazy. Maybe it's some kind of OCD. So, but anyway, yeah, I usually on Christmas Eve or New Year's Eve, my husband loves me. He's like, I guess the decorations are coming down. I'm like, well, either today or tomorrow. Your choice, buddy. Anyway, everyone have a really good new year, and we'll see you on the other side in 2025. Make it a great day, make it a great rest of your week, and thank you for listening to the Codecast podcast.
For more information on medical coding, billing, auditing, and compliance, including how to hire Terry, follow Terry on Twitter at TerryCoder1 or visit her website at www.terryfletcher.net. Podcast producer Joe Kuzma. Music producer Dassassin Music.